So I'll quickly run through so much data about what happens when a bone fractures in the spine, and there's always a confusion in our practice that when we see a patient with a single vertebra plana, ye kya ho raha hai? And we try to get the pieces of the jigsaw puzzle together. And of course, the straightforward way to do it is to go through the standard warm-up, go through the clinical presentation, run through the differential diagnosis in your head. And for my money, this is the way it pans out. The most common likelihood is osteoporotic fracture, followed by TB, followed by myeloma, followed by MET, followed by primary round cell tumor. And that's how the order goes in our experience or our practice. As far as clinical evaluation goes, there's very little to choose because all these patients come with back pain. Many of them do have constitutional symptoms. That's an overlap. And of course, if there is neurology, then it solves your problem because it forces you to go in and then you have the diagnosis and then everything is fine. As far as X-rays go, probably the most, the easiest or the most likelihood of cracking a diagnosis based on X-ray alone is when you see a vacuum sign, like Bhavin very elegantly showed us, that if there is this kind of a black hole in the middle of the bone, it's most likely going to be a benign osteoporotic fracture. It's very unlikely that this will be pathology. Remember that this black hole closes down when you make the patient sit up. It looks white because it's full of synovial fluid. It looks white on MRI scan, and it again looks black on CT scans, and that is the Kumel lesion. However, if the osteoporotic fractures at the end plates, like in this situation, it can make things confusing because infections look pretty similar to this. And hence, if you have an osteoporotic end plate collapse, you've got to start looking at other markers and think of infection, of course, being in India, think of TB, and look at the ESR if it's raised, look at, other soft tissue, etc. on the MRI scan. MRI scan becomes mandatory for all these patients. In fact, any path fracture, you must get an MRI scan done, whether you're convinced about it being osteoporotic or not. The confounding factors with TB is that it no longer presents with constitutional symptoms, and invariably TB labs are often normal, and there's no way to diagnose tuberculosis except biopsy. And I show all these cases that came to our clinic, which were, and they were on empirical AKT from all over the country. And if you see, the problem is that none of them were TB. And hence, diagnosing TB on the basis of the MRI scan alone can be your undoing in practice. The plot thickens when TB also can present in a very funny manner, and all these cases, which none of them actually look like TB on MRI scan, all collapsed vertebrae, but none of them was actually tuberculosis. So you can see how, our radiological diagnosis can be found wanting. Again, things get worse because TB and pyogenic infection, there's very little to choose from. And in the past, everything would be TB. Nowadays, more and more pyogenic infections have been coming up in our country also. However, the clinical examination or the clinical picture of the patient can actually, sort that out in your head. And the, very short history of a very, very symptomatic, painful patient, bed shake sign, you go in, say, hi, hello, how are you? And kick the leg of his bed, and he will yell out in pain because he's very, very unstable. And these guys have a high count. They often have a history of bacteremia, high WBC count, CRP is skyrocketing. Most importantly, there's less destruction than expected on the clinical picture. He looked very bad clinically, but his X-ray may look as normal as this does. And this is because the symptoms race ahead of radiology. Also, in pyogenic discitis, the disc lights up because it's a proteolytic enzyme. It eats up the disc. Unlike in tuberculosis, where typically the disc is spared and you get adjacent bony osseous involvement, and you get a sandwich lesion, which is a spondylodiscitis. Now look at this case, which was being treated as tuberculosis because it looked like a lesion with the end plate affected, and we gave the he came with a conus lesion, so we gave him methylprednisolone, and he got better. But eventually we found out that it was actually a lymphoma. So the problem of diagnosing infection versus tumor again comes up, and even a studded spine like that is not necessarily a tumor. It could be TB. However, there are 2 or 3 signs that you must look for. Ballooning of the posterior cortex, as you can see here, is a clear-cut sign that you want to think of tumor. A winking owl sign where there's pedicle destruction, which actually happens because this tumor permeates through all 3 columns and it doesn't stay alone in the anterior column. It moves through and attacks the pedicle and the posterior column. So if you see this kind of a permeative lesion on MRI, and of course if it's a studded lesion, you think of studded spine, you think of metastasis, but it could be multifocal TB. The way to differentiate it that the person who belongs to this MRI will be very asymptomatic if you had tuberculosis, and he would be very, very symptomatic if you had metastasis. The lab markers often don't prove so effective, and PET scan is one of the new ways of moving forward. Multiple myeloma, the red box is what I want you to read just for 30 more seconds. It can confuse you with advanced osteoporosis, and you have to have the element of doubt. If your ESR is higher than 100, you've got to think of multiple myeloma. Hemangiomas, the giveaway is MRI and CT scan. On CT scan, you'll see that speckled dot appearance. Remember, patients with hemangioma worsen during pregnancy. If there is an end plate to end plate extension of the hemangioma, there's a likelihood of the collapse happening, like in this patient. And treatment is pretty slick now. Eosinophilic granuloma, it may be rare, but it can present as a bolt from the blue, like this kid. It's a dry collapse, no soft tissue. Both the discs are preserved. And they don't need any treatment. ABC, on the other hand, nowadays can be treated just with biopsy. It's been proven that you do a biopsy and bone starts to regenerate. And for giant cell tumors, which also present like a permeative lesion, denosumab has been a game changer. But when you have to operate, it has to be an end block resection. And finally, a simple small node with low vitamin D in a young kid can present as a collapsed vertebra. And you've got to keep that in mind when it lights up on the sides. In the end, biopsy would help you make a more correct diagnosis than second guessing. Thank you.